the arm, forearm, and hand. And as we do, we're going to answer a few questions like, what nerves provide motor innervation to the muscles of the arm, forearm, and hand? How can we group muscles to make it easier to learn these innervations? And what are the clinical presentations of injuries to these nerves? So I wanted to start by talking about fascial compartments. Fascial compartments are typically muscles that are organized into compartments that are surrounded by fascia. And so we can see a couple here. So we've got a right upper limb. We can see we've got like this anterior compartment right here. We kind of got a dividing line there, fascia. So those muscles are all going to be grouped together, innervated by a single nerve. And then the posterior compartment in the back will be its own compartment innervated by its own nerve. Typically, a single nerve will innervate all or most of the muscles within a compartment. So the upper limb compartments that we'll see are the anterior brachium, or the other word for brachium is arm. Again, that's from the shoulder to the elbow. Then we're going to see a posterior brachial compartment, an anterior antebrachial compartment, or the forearm. So again, elbow to wrist for the antebrachium, posterior antebrachium, and the hand we're going to see as well. So all of the muscles in these compartments are going to be innervated by the same nerve, except for a couple of the compartments are going to get two nerves that we'll see. The first nerve we're going to talk about is the musculocutaneous nerve, and you can see it's right here, kind of the top of RM, and it receives contributions from C5, C6, and C7. Injury to the musculocutaneous nerve may present as diminished ability to flex the shoulder and elbow. It may also present as a pronated forearm, and then there will also be loss of cutaneous sensation from the skin over the lateral forearm. And so you may have guessed from the image, but the musculocutaneous nerve is going to innervate the anterior brachium. And so the muscles that we're going to see there, the first one is the coracobrachialis. That one does shoulder flexion, adduction, and internal rotation. And we can see that muscle right here. So we've got the coracoid process, coracobrachialis muscle. And in most individuals, the musculocutaneous nerve, it's kind of right here, it will pierce the coracobrachialis to enter that anterior brachial compartment. The next muscle we're going to see is the biceps brachii. So on this image, it's been cut here, and then the two heads have been cut. That muscle, it does shoulder flexion, elbow flexion, and supination. And then the final muscle innervated by the musculocutaneous nerve is the brachialis muscle, which just does elbow flexion. And we can see that kind of deeper. It starts here and then goes to that ulnar tuberosity. Talking about the clinical presentation, we can see pretty much all these muscles either doing shoulder or elbow flexion, so that makes sense. But then it says they're going to have a pronated forearm. None of these muscles do pronation. So the reason they're going to have a pronated forearm is because the biceps brachii can no longer supinate. So if they can no longer supinate and oppose the pronators, then the forearm will be pulled into pronation. And then the musculocutaneous nerve, it's a great name because it does these muscles and then it does cutaneous sensation. So for the sensation from the lateral forearm, we can see this portion of the nerve that continues after is just doing the skin of that area. And then to get another view of the musculocutaneous nerve, we can see we've got the axillary artery here. We've got our M, and at the top of the M is the musculocutaneous nerve right there. And that is piercing coracobrachialis to get to that anterior brachial compartment. Okay, the next nerve we're going to talk about is the radial nerve. We can see it right here coming off the posterior cord. That receives contributions from C5, C6, C7, C8, and T1. It's just getting them all. And so the radial nerve, on its pathway, you can see it's right here. It goes through this triangular shaped area, and we're going to call that the triangular interval. So it's between the long head of triceps, teres major, and then the humerus. And then it also, as it goes through there, it then wraps really tight around the humerus on the radial groove. Switching to an anterior image, we've got the radial nerve here going through that triangular interval, and then it's wrapping on the posterior humerus in the radial groove. And so an injury to the mid-humerus, like a mid-humeral fracture, could injure the radial nerve since it's so tight around the humerus. Injuries to the radial nerve may present as diminished ability to extend the shoulder, extend the elbow, extend the wrist, and or extend the digits, depending on where the injury occurs. And then it will also present with a loss of cutaneous sensation from the posterior arm, forearm, and or the posterior aspects of digits 1 through 3. And so you may have guessed it from all of the extension that would be lost, that the radial nerve innervates the posterior brachial compartment and the posterior antebrachium. So the radial nerve should be your favorite because it just does everything posterior. In the posterior brachium, we have the triceps brachii doing shoulder and elbow extension, which you can see right here. And then in the posterior antebrachium, we have 12 muscles. We're not going to go through all of them, but they're basically all doing some sort of extension. So wrist extension, digit extension, thumb extension, and again, all innervated by the radial nerve. One of the exceptions that I'll just talk about really quickly is brachioradialis. It actually crosses the elbow anteriorly, so it does elbow flexion. So sometimes people can get tripped up on this, but it is in the posterior antebrachium, so it is innervated by the radial nerve. The next compartments we're going to talk about are the innervations of the anterior antebrachium as well as the hand, because both of these are innervated by two nerves. One of those nerves is the median nerve here. It's the middle of our M, and it receives contributions from C5 to T1. The second nerve is the ulnar nerve, kind of the inferior part of our M, receiving contributions from C7 to T1. So we'll start with the anterior antebrachium, and you can see we've got all the muscles listed here. And the first one we're going to talk about are the muscles innervated by the ulnar nerve, which we've got on our image. So as we follow the ulnar nerve, we see it wraps posterior to the medial epicondyle of the humerus. And so the ulnar nerve is actually kind of like the funny bone nerve. So whenever you hit your funny bone, you're hitting or compressing the ulnar nerve as it wraps around the medial epicondyle. And with this as well, it's clinically significant because fractures to the medial epicondyle can injure the ulnar nerve. So the ulnar nerve will continue down, and then we see it's innervating 1.5 muscles here. And so when we look at the list, I'm seeing, okay, we've got one muscle here that's ulnar in its name. So it makes sense that the ulnar nerve innervates flexor carpi ulnaris, which is this guy right there. And then this other muscle it's going to do is the flexor digitorum profundus, but it's only innervating the ulnar or the medial half of this guy right here. So we've got ulnar nerve doing the one with ulnar in its name, the flexor carpi ulnaris, and then the ulnar half of flexor digitorum profundus. And then you can see that the median nerve is basically innervating all of the other muscles. For the deep muscles, they're innervated by the anterior interosseous nerve, but that is just a branch of the median nerve. So to simplify that chart and recap the anterior antebrachium, I remember just what the ulnar nerve does, and then median does everything else. So ulnar nerve does the flexor carpi ulnaris and the ulnar half of flexor digitorum profundus, and then the median nerve I just remember takes care of everything else. So moving on to the hand, again we can see we've got a table with all of the muscles here, and again it's going to be the ulnar nerve and median nerve that are involved. Looking at this image of the hand, we've got the ulnar nerve here passing through, and then the median nerve right here. And as we follow the median nerve, we can see it passes through this area. This is the carpal tunnel that's passing underneath and through. And then you can see it's by the thumb, so it's kind of getting this thenar eminence, and it's getting kind of these first couple of digits here, so digits 2 and digits 3. And so when we put it onto the chart, the median nerve getting the thenar eminence, and then the first and second lumbricals are done by the median nerve. And the first lumbrical is right here, goes to the second digit, and then the second lumbrical right here goes to the third digit. And then in the hand, I just reverse it, so I remember what median does, and then ulnar does everything else. So we'll put that up now. Ulnar nerve innervating the rest of the muscles in the hand. And just to simplify that, how I remember it, median nerve, it's innervating 1/2 loaf in the hand, so the 1 and the 2 for the first and second lumbricals, then opponens pollicis, abductor pollicis brevis, and flexor pollicis brevis. And then the ulnar nerve is doing everything else in the hand. And now that we've talked about the innervation of the anterior forearm and the hand, I want to go over 2 clinical cases. So we see we've got 2 different patients here. And the context of these issues, this patient is trying to make a fist, and you can see digits 2 and digits 3 are not able to comply. And then this patient here, they're trying to either extend their digits or just at rest, digits 2 and digits 3 are having issues. So the functional deficit we'll talk about first with this patient. So it looks like their MCP, PIP, and DIP are extended. So that means that they cannot flex their MCP, their PIP, or their DIP. And so the muscles that might be involved with that, I know flexor digitorum superficialis, that flexes the MCP and the PIP. Flexor digitorum profundus flexes all of these. And then the lumbricals flex the MCP. So those are probably the muscles involved there. And then for our second patient, you can't really see on this image, but their MCP is extended, and then their PIP and DIP joints are flexed. And so that means that they probably cannot flex their MCP since it's extended, and then they can't extend their PIP or DIP since those are flexed. So the muscles involved there, that is just going to be the lumbricals, because the lumbricals flex the MCP and then extend the PIP and DIP. So both of these patients are having issues with digits 2 and digits 3. So I'm thinking it's probably a median nerve issue for both of them. So you can see we've got an image here, we've got the median nerve, and then we need to figure out where the lesion is for each of these patients. So for this first patient, the muscles that are lost are the flexor digitorum superficialis, profundus, and the lumbricals. And so you see here we've got flexor digitorum superficialis, and that is being innervated by the median nerve very proximally. And so this is most likely a proximal injury to the median nerve. And one of the areas that that can occur is here if there's a supracondylar fracture of the humerus that would injure the median nerve and cause these proximal issues that we're seeing. And then for this injury, it's just the lumbricals that we're seeing injured, so most likely a distal median nerve injury, and where that can occur is as the median nerve passes through the carpal tunnel. And to wrap this one up, we're going to name these conditions. So this first one's called the hand of benediction, and then the second one we've called this the median claw. Since the lumbricals play an important role in these conditions, I wanted to just do a quick review. On this image, we've got a palmar view of the right hand, and you can see we've got the first lumbrical here going to the second digit, and then we've got the other lumbricals here as well. And then if we look and get a lateral view of the digit, we've got this view here, and so this would be the lumbrical, and you can see at the MCP joint, it's crossing that joint anteriorly, so it's going to do flexion, but then it loops posteriorly, so it's going to do PIP extension as well as DIP extension. And to finish up this video, I want to do a quick review of what we've gone over. So we learned that the musculocutaneous nerve innervates the anterior brachial compartment, and it would present with weak flexion of the shoulder, elbow, and a pronated forearm. And then the radial nerve innervates the posterior brachium, posterior antebrachium, and then that's just everything extension. So weak extension of the shoulder, elbow, wrist drop as well if they cannot extend. And then the median nerve, we learned, innervates everything in the anterior antebrachium that the ulnar does not. And then the hand, it does 1/2 loaf. And presentation, we may see weak wrist flexion, digits 1